Welcome to this satellite session on lessons from the World Bank's early response to the COVID-19 pandemic and what they mean for future crisis preparedness. My name is Oscar Calvo, and as Acting Director General of Evaluation at the World Bank, it is my privilege to get this session started. When the pandemic hit, it unfolded quickly, causing much uncertainty and, of course, pain and suffering. It was also a test like no other about the preparedness of the international community and of governments to prevent, detect, and respond to health threats such as the one presented by COVID, and especially a test of their ability to protect vulnerable communities. If the shock was overwhelming, the response was unprecedented. For both of these reasons, it is truly worth reflecting about this period. The spirit of this session today is to draw lessons from the successes and the challenges of this experience so that they can be applied towards future preparedness. This is indeed the underlying spirit behind an early stage evaluation that we conducted at the Independent Evaluation Group of the World Bank, which assessed the quality of the bank's support to the health and social response to COVID during the initial 15 months of the pandemic. The evaluation team, Jenny Gold and Stephen Porter, will present the main findings of our report in a moment, but I would like to share with you two brief reflections before I give the floor to them. During the initial period of the pandemic, the World Bank delivered a historic response, acting with speed and to scale to reach countries most at risk of suffering losses in human capital and development losses more broadly. At the onset of the pandemic, time was a major constraint. To put it in the simplest terms, there was just no time to build resilience from the ground up. And indeed, we found that the World Bank was most successful when it was able to leverage capacities and systems that were in place before the crisis. Where systems were weak or lacking, the response was less successful. So this evidence points to a strong rate of return of previous investments in human development systems and the impact they have in responding to a pandemic. This is a theme that is picked up in the evaluation report, which identifies some specific challenges and opportunities in this regard that can be picked up later in the session. The second reflection I wanted to share is about the impact of building links across response efforts. What we found is that organizations and institutions were more effective when they talked to each other. Re-established collaboration channels allowed them to deliver a more coordinated response at the speed required during a crisis. In other words, time is of the essence, but it is not the only factor. The pandemic response was of a better quality when interventions of a multidisciplinary nature were coordinated across different sectors, where close monitoring took place and data was collected and used. When those circumstances were present, what we found is that it was easier to come up with new solutions that helped broaden the range of support and made it possible to reach communities with better services when they are needed most urgently. But considering these and other lessons can help countries and the World Bank and its partners support the type of systems that lead to better preparedness. Our hope is to contribute to these efforts by building up the evidence base. With this, I will now pass the floor over to Stephen and Jenny to present more insights from our evaluation. Our moderator, David Wilson, who is one of the leaders of the World Bank's response, will then facilitate the discussion to reflect on these and other issues raised in the report. The chat box is now open for everyone to direct questions to presenters and panelists throughout the session, and I encourage you to participate. Thank you, and I look forward to today's discussion, especially in view of the distinguished panel and audience that has been assembled. Over to you, Stephen.
Thank you, Oscar. I just want to check you can see the slides. Great, thank you. So Jenny, I will now outline the lessons from the World Bank's early response to support COVID-19 for future crisis preparedness from the social and economic, social and health response. So first, we're going to discuss the evaluation's methodology. Second, we'll talk through the drivers of success. And third, we'll come to our lessons. So first, the note on evaluation methodology. The main question that the evaluation answers is, what has been the quality of the World Bank's early COVID-19 response in countries in terms of saving lives and protecting poor and vulnerable people? To answer this question, IEG used a theory-based approach. The theory of action that you see on the left-hand side of the screen outlines dimensions for the assessment of the quality of the response. The theory of action posited 3 interrelated areas that define the quality of the response, each with specific dimensions for which the evaluation gathered and triangulated evidence. On the left, we looked at that support to needs needed to review the relevance of the World Bank's large early scale response. To the right, we looked at whether operational processes and partnerships and how well they helped and how well World Bank internal processes, instruments and partnerships support a smooth and speedy early response. At the bottom, implementation and learning assess the early outputs of the response. The evaluation adopted a multi-level mixed method approach that combines quantitative and qualitative evidence. In this, we employed 8 methods to collect evidence at 3 levels: country, portfolio, and corporate. The country level was the focus of the evaluation, with the portfolio and corporate evidence helping to enrich the analysis and triangulate findings. The conceptual framework of the evaluation focused upon 5 response areas. These on the left-hand side, under the blue headings. These response areas were the main elements of the World Bank's health and social support to COVID-19 in the early response. And the evaluation covered the relief and restructuring stages of the response during the initial first 15 months. I'd like to direct your attention to the grey relief stage, just next to the blue response areas. This stage and its interventions were critical immediately in the COVID-19 response, as in within the first few weeks and the first few months. Some areas in the relief stage are interconnected, for example, ensuring child welfare, and the social services also interconnects with protecting poor and vulnerable people. It is important to note that institutional strengthening was included in the release stage and focused on coordination and public health functions. The restructuring stage of the COVID response can overlap with the release stage. The restructuring stage sought to strengthen systems and policies for public health preparedness and restore human capital. The recovery stage had yet to be reached early in the COVID-19 response, but relief efforts and some initial restructuring are intended to be put in place as building blocks to the transition stage. I'll now turn over to Gianni to talk about the drivers of success.
Thank you, Stephen, and good morning, good afternoon, everyone. So the evaluation identified 5 drivers of success, which could help to inform future preparedness. These include strengthening integrated disease response capacities at regional, national, subnational levels, so engaging all the way to community to include the demand side. Developing readiness across sectors to expand support in a crisis to address those multiple needs and uncertainties. 3, ensuring continuation of essential services and expanding services for vulnerable groups in a crisis. 4, better systems for real-time monitoring of local services. So we have this quick feedback for decision-making in a crisis, including citizen feedback and just continuing evidence learning on what is working. 5, ensuring a range of instruments and partnerships are in place to respond at different timeframes in a crisis. So those speedy support that respond within the first days, but then also some longer support that can take place in several months, for example. During the early response to COVID-19, there was a quick action to scale up support across countries, emergency health support in particular, such as testing for COVID. This helped reduce the threat of COVID. Over 80% of the countries that we looked at in the evaluation did this. Having previous preparedness helped countries move quicker, as did having coordination structures in place, such as One Health platforms. Important was that national coordination was integrated to local levels to support implementation and to regional levels to support learning, leadership, and rapid actions. A challenge for future preparedness will be building these linkages between response capacities at different levels. Overall, in the early COVID response, there was not enough attention to these connections between local government, especially communities, but also even at the regional level. Networks reaching local levels, such as disease surveillance, health provider networks, nutrition networks, were instrumental to engage frontline workers and for case identification and risk communication. Regional coordination was important for solving challenges, quick learning, and scaling up of policies across countries, for example. And go to the next slide. Going forward, improving cross-sector capacities will also be important, and this preparedness across sectors. In the early COVID response, addressing needs of government required engaging water, agriculture, social protection, and many other sectors. Integrating planning helped countries such as Senegal and India respond to the many needs that were happening on an ongoing basis and the many uncertainties. It engaged the surge capacity across sectors. In World Bank programs, we could see that where there was experience of sectors to address the different needs, they could respond more comprehensively. Areas more difficult to respond were those that had received less attention before COVID-19, such as to urban health risks. I just want to draw attention to this chart. So if you look at the light blue and dark blue lines, this shows you that over half of countries had a high or very high response to the needs that were emerging during the COVID response in the World Bank's country program. Again, it was more challenging where there was less previous experience. The engagement across sectors also supported innovation. And many of these innovations could offer solutions going forward for scaling up and preparedness if we learn which ones work and which ones are more effective. I want to draw your attention to this chart, Stephen, if you can. The blue, it's quite busy, but the blue area are those innovations relating to health. And what I want to point out is there could be more innovations looking at support to local health workers and risk communication, which were key challenges of the response. And if you look at the yellow, these are the community level. And again, there could be more innovation at this level as well. The evaluation also identified continuing essential health services as an important factor for success in a crisis response. This is also a lesson from Ebola. About half of the countries looked at in the evaluation really were able to emphasize this, but it was challenging because they had to do this on top of the emergency response. For example, Mozambique does stand out in its efforts. Countries were overwhelmed and they lacked preparedness to continue services. The capacity of the health system before COVID was also a factor, as expanding COVID efforts was smoother in countries with greater health capacity often. Disruptions in the use of essential services were challenging. Stronger essential services will be key in terms of building resilience going forward. Drawing your attention to this chart, the dark blue bars are those areas where there was just less readiness to respond in COVID. And I just want to emphasize here that essential health services and support in communities were among those areas. Learning. In education, there was a wide scale up of innovations quickly with partners to respond to the crisis. In countries like Djibouti, they worked with parent and teacher networks to reach communities, for example. However, the needs were vast in this sector, and overall, the education system was not prepared. And there was a lack of evidence on what were the most effective ways to engage, and a lack of networks set up to reach communities. and also to cover vulnerable groups. So there's a need for more learning in terms of which of these innovations were the most effective going forward. So engaging vulnerable groups and addressing gender was another challenge and lesson. Scaling up social protection in COVID was quite well done across countries that we looked at in the evaluation. It happened quite quickly, and there was often a gender element to the social protection response. And this is quite different from past crises. The strong social protection support was due to extensive preparedness. There was lots of analytical work on digital systems done prior to COVID, which could be quickly built on in countries like India, for example. Other support to address gender and reach vulnerable groups, such as support to address gender-based violence, sexual and reproductive health services. Often countries were just not prepared to scale up this support in the crisis, although there are good examples of where it did happen. Even you can go to the next slide. So now the monitoring and learning is the fourth lesson. The World Bank had a very close navigation with countries and discussion to address needs during the early COVID response. And this was helpful, and there was also a good effort to strengthen surveillance systems, which needs to continue, including laboratory networks. However, a persistent challenge was monitoring data to inform decisions. So key was having information on the success of local interventions in health and other sectors, and feedback from beneficiaries. Without monitoring data, decisions were often based on national dialogue and ongoing dialogue, but it was challenging to know what was working in communities. Using SMS text messaging to track medical supplies and feedback of services are some examples where this was done in countries, and dashboards across sectors, but these are not the norm. Drawing your attention to the diagram, so yes, okay. So in the evaluation, we looked at what were factors that were important for satisfactory implementation of the response. And I just want to draw your attention to the top of this diagram, which shows monitoring and citizen engagement. Where this was available, it was very helpful for the response and important. I'm going to pass over to Stephen.
Thank you, Jenny. Partnerships and instruments were key for timely and flexible support. The flexibility given to country teams in the early months of the response was key to rapidly adapting their existing portfolio of projects and advisory services and analytics in different sectors based on local policy dialogue. Existing partnerships between development organizations and the World Bank helped preparedness and crisis response in countries. Partnerships developed by the World Bank before COVID-19 often provided technical knowledge and financing for the health and social response. Important partnerships identified in interviews, documents, and case studies included a wide range of development organizations. For example, EdTech partnerships with the Education Global Practice helped scale up e-learning. Supplement country governments, capacities, and procurement agreements with UN agencies supported the delivery of goods in more than 40 countries. Further, the World Bank collaborated with the private sector to facilitate the procurement of medical equipment and supplies. An important lesson is that finance can be sequenced in responding to a crisis. As the chart to the right shows, up to May 2020, crisis instruments, grants, repurposed projects, regional projects provided the bulk of the immediate response and helped the World Bank provide support to governments rapidly and flexibly in the early months of the COVID-19 response. About 70% of countries successfully received disbursements from COVID-19 projects in the first 3 months of the response, a rapid pace for the World Bank. From May onwards, new policy and programmatic financing in the blue and red became the main financial support to the COVID-19 response. And then from January 2021, we now start to see new project financing in the green becoming an important element that supports the recovery stage of the response. Strong internal leadership at multiple levels enabled rapid increases in spending, innovations, and information sharing that helped coordinate the response. For example, spending allocations were front-loaded, and an emergency operations center led by the Human Development Practice Group facilitated technical coordination, adaptive management, and problem solving for the response. Moving now to lessons. 4 main lessons arise from the report. First, ongoing recovery efforts can strengthen the resilience of essential health service and education services to ensure that development gains are protected in future crises. For example, in health, countries can be assisted to strengthen telehealth and other platforms for continuing essential health services in an emergency. Second, a gender equality lens needs to be applied to health and social crisis response actions across sectors. Areas that support gender equality which could be further considered include psychosocial support, sex and reproductive health, income and asset accumulation, and community engagement. Third, regional cooperation can help facilitate political leadership, technical learning, and multi-sector coordination. Such support could help strengthen preparedness in countries through One Health platforms that provide greater emphasis on connections between human and animals' health, critical health services, and demand-side activities such as citizen engagement. Finally, building on the COVID-19 experience can also strengthen the World Bank's internal crisis preparedness. For example, the World Bank can also explore innovative ways to strengthen the use of crisis instruments for those immediate response in countries. Those first few hours, within days, within the first week, through such support, being able to connect greater to communities. Thanks, and we'll hand back over to the panel.
Thank you very much indeed. Can I take over the panel now, Jenny and colleagues? Let me just begin by saying how grateful we are to IUG. It's always a pleasure to work with them. They're perhaps the most reflective and thoughtful part of the World Bank, and we always value their insights. And we now turn to a really experienced panel, and I'll just make a couple of initial observations. As we look at the lessons from COVID, the first one is how important it is to learn the lessons, but not to prepare ourselves to fight the last war. Perhaps the thing we can be most confident about is the next pandemic is unlikely to be another coronavirus. We have so much cross-reactive immunity. There may not be an immunological niche for it. So we need to be prepared for the unexpected. And the second point to stress is that while we prepare for pandemics, we should strengthen ourselves and battle harden ourselves against today's outbreaks, the hemorrhagics or filoviruses that are raging now through countries such as Equatorial Guinea, Mpox, and sadly, the resurgence of cholera. So let's test our pandemic preparedness against today's outbreaks. And finally, as we learn the lessons, just the real importance of looking closely at the trade-offs. I think among senior bank leadership, the primary reflection on COVID is how catastrophic prolonged school closures were, causing irreparable damage to a whole cohort of children who may lose 10% of their lifelong earnings, an estimated $21 trillion. And remote learning did very little to mitigate this disaster. So with those preliminary observations, I'll turn to a very distinguished panel, beginning right at the coalface and in the field with a distinguished colleague from WAHO, the West African Health Organization, who's been at the forefront of so many outbreak responses. I'm pleased to ask Cesare Abanzo to speak, and specifically, I'd like you to share your impressions and lessons from COVID from someone who's been right at the front line of this and other outbreaks. Over to you, Cesare.
Thank you, David, and good morning or good afternoon or even good evening to all of our auditors. I'm Cesare Damiahanzo, like David mentioned earlier. So I'm senior health specialist in the bank and former coordinator of the World Bank portfolio with ECOWAS, coordinating 5 projects, including the REDICE project. So I will be talking from the standpoint of the then coordinator of the REDICE project and what we have achieved during the COVID-19 response. First of all, I would say that the good quality of the response we have seen in Africa, basically in sub-Saharan Africa, is not something that could be taken as granted. It's something that was prepared from the previous EVD outbreak that the continent acknowledged from 2014 to 2015. From that point, there was a common sense that we need to strengthen our preparedness and response system. So many partners supported the region, and that was the case for West and Central Africa. For the West Africa, we had a lot of initiative, and I will be talking about the Redice project, which is a $600 million, more than $600 million invested in West and Central Africa. That is dedicated to support the surveillance system, the laboratory system, and the preparedness system. So the Redice project has been instrumental in harmonizing policy, strategy, and guidance. For example, the Redice project has supported to develop preparedness strategy in West Africa and Central Africa, laboratory regional strategy, and also has supported to conduct a lot of initiatives such as simulation exercises, for example, on many outbreaks, Lassa fever, Rift Valley fever, and many other outbreaks. Beyond that, the project has supported to, let's say, train many experts in surveillance, laboratory, and preparedness. For example, more than 100 experts has been trained in FLTP master degree by WOW. WOW is the health branch of the ECOWAS. And more than 70 centers for epidemiological surveillance has been established across the region. So just to give you a bit sense of what has done before. But during the pandemic, what has happened? When the first outbreak was, the first case was reported in Wuhan in China, Africa's CDC has activated its Emergency Operations Center for COVID-19 to coordinate effort at various levels. And in that vein, on 15 February 2020, there was the Bamako ministerial meeting that set out clear mandate to WOW, the West African Health Organization, in terms of how to address the COVID-19. And in that vein, what did WOW do to address the COVID-19 with partners? And when I say partners, I mean WHO, the World Animal Health Organization, FAO, OIE, the universities, and the research institution. They was able to do key intervention on provision of essential medical supply in terms of diagnostic and treatment resources such as reagent provision of reagent, sanitizer, PPE. They provided financial support to the member state and also help them to mobilize additional support. For example, WOW was able to mobilize $45.5 million from partners, in addition to the Redice financing that is already there on the field to support surveillance activity, laboratory activity, and preparedness and response. At the same time, Redice countries were able to repurpose $85 million to address the COVID-19 before the World Bank established its project of COVID-19 strategic preparedness and response project of 20 billion across the world. So imagine that flexibility of mobilizing World Bank existing financing of 84 million. That was what supported member states to trigger the response on the field, something unprecedented, unbelievable. I'm not only talking about the World Bank, many other partners follow, like GIZ, like ADB, like AFD, and many other partners. So that togetherness, coordination, intervention around WOW through the ministerial committee has been something that has weighed a lot in the quality of the response against the COVID-19. Let me stop here. Over. David.
Thank you very much indeed, Cecilia, for beginning us exactly where we want to begin, at the heart of so many outbreaks and epidemic and pandemic challenges, and for grounding us so well. I'm now going to move to somebody who's an old friend and collaborator of the World Bank and who comfortably straddles academia and application, Victoria Pham, who we've known in a previous and current incarnation at the Centers for Global Development, who've really taken an interest in multilateral banks and their evolution. And I followed her work very closely from Hawaii during COVID, and it was a constant beacon to me. Victoria, I'm very pleased to ask you to share your experiences of the lessons of COVID, and in particular, how we can strengthen health systems to withstand emergencies, and also, even more difficultly, to ensure the continued delivery of services during crisis and recovery afterwards. It's striking how few health systems worldwide have recovered from COVID. It's something we don't pay enough attention to. Victoria, over to you.
Thank you, David. Your remarks are very kind. I've also been following your work as well. But before I talk about strengthening health systems, during and after a pandemic, I just want to congratulate the authors and IAG for this very important report. The IAG function of conducting independent rigorous evaluation is hugely important in general, but I think especially so in learning lessons from the COVID pandemic, which was just disastrous on so many levels, and for which the world as a whole and all of our different communities are still trying to learn those lessons. So I think in that sense, this report will help us to continue to learn, and I hope other multilateral agencies also do their own kinds of evaluations and reports as well, in a similar vein as the IAG. I should mention, as David noted, my remarks reflect my recent work at the Center for Global Development, where we've been working on pandemics and pandemic preparedness and response, but also my lived experiences working in local pandemic response, working in close partnership with the state of Hawaii government as well. So as we all know, the excess deaths as a result of COVID, but not just COVID, which is to say other diseases and conditions, has been very large around the world. And of course, these stem not just from potentially interactions with COVID and chronic diseases, but the disruption to essential health services, as well as potentially travel disruptions as well. And as a result of this unprecedented impact on excess mortality, the world has seen unprecedented drops in life expectancy, right? So, and in some countries, this life expectancy has not bounced back. So I think in parts of Western Europe, there was sort of a gradual or quicker return back to a life expectancy on track. But in places such as Eastern Europe and the United States, we're seeing a continued sustained deficit of life expectancy, and that's very, very concerning. And what might explain these drops in life expectancy, and even the shorter term drops in, say, Western Europe and other parts of the world, I think we're really talking about both on the supply side and the demand side. So on the supply side, it could be the changes in behavior by providers in terms of limiting access to regular services. As we all know, it suddenly became much harder to see the doctor, as well as transitions to virtual and telemedicine. And not to mention the widespread provider burnout and attrition. There's huge workforce challenges as a result of COVID. Now, on the demand side, we've seen changes in behavior by patients and households and their seeking of services, I think in large measure due to risk aversion and fear of infection. And those, I think, even now have persisted as well. And in terms of these broad multi-disease impacts of COVID, it's not just sort of the standard biomedical or sort of physical illness, but also widespread mental health impacts as well. So it's just multi-disease and multi-health condition. Well, that's sort of the problem, laying out the problem of what we're seeing in terms of essential health services. And I think as countries move forward, we need to learn not only from the lessons of COVID, but also reflecting even further back to other pandemics as well, including SARS. I think this need for planning is something that we should not take so lightly. This cycle, we call it the cycle of panic and neglect. It already sounds too blasé, I think, but maybe we can put it differently and say we should somehow avoid being perpetually surprised and avoid being perpetually unprepared for crisis after crisis. And we really need to learn from these experiences and get better the next time. And I think my comments will really reflect on how countries and institutions can learn from experiences, which I don't think we can take for granted. A report does not mean necessarily that those lessons are absorbed. We have to really think through how those lessons can be institutionalized. I think one key approach to institutionalization, but also one key approach to addressing the strengthening of health systems is clear and simple communication. And that is an important policy and programmatic tool, not only for government officials in building trust, and I think it actually goes beyond just the approach of monitoring, which I think is one important sort of way in which information is collected, but it's really a sort of a two-way communication in which information can come from local levels up to national, international, and then likewise internationally back down. So that communication really needs to be two ways. And as we think through all the different kinds of COVID measures that were implemented, they all required the willingness of the public to participate in them. You know, although there was some level of mandate and authority and sort of the obligatory, you must do this sort of mentality, in the end, very much so was voluntary, in the sense that getting people to wear masks, even if it's mandated, still requires people's willingness to do so. And same thing with social distancing. And so in that sense, getting the public support is essential for any country to succeed, and getting the public support requires building trust, primarily through communication. And in order for communication to work, we need existing communication channels for that to happen, whether it's television, radio, online. All of these infrastructure and technologies, digital tools, are absolutely essential. So to the extent that broadband and enhancing access to mobile, computer, internet technology, and other sources of information, the newspaper, for example, and of course electricity, are absolutely essential to improving communication in low and middle income countries, and I would say very much so in high income countries as well. So that's sort of my key, one key message is the importance of communication, and that communication can also reinforce the importance of, even in the pandemic, that access to essential health services should not be going down. That is a really important message that I think was not well communicated at many different levels of government. As we think through sort of planning and sort of improved institutionalization, I do think the experiences from countries that experienced SARS, particularly in East Asia, places such as Hong Kong, Taiwan, Singapore, Korea, of course, not everyone can be an East Asian tiger, but I think these places learned the hard way about how to better plan and respond to a pandemic. And as I just mentioned, experience on its own does not guarantee greater preparedness. And if you think about it, the leaders and the staff who went through the SARS, they were not the same leaders that responded to COVID. And so there were intergenerational transitions, transfers of knowledge between senior generations and junior generations. And so I think this intergenerational transfer of information and knowledge was enabled by the institutionalization and operationalization through plans. Plans are these very humble documents that tell us how we can be better prepared, but I don't think they should be discounted in terms of their importance. These East Asian countries also learned the risks of the reduced access and availability of essential health services during a pandemic. And many of these East Asian countries had, as part of their planning, plans to, for example, designate certain healthcare facilities for respiratory or febrile illness in order to protect patients and providers at other healthcare facilities for chronic conditions. And that kind of provider assignment, of course, requires some minimum level of healthcare supply, as well as communication. It requires communication with the partner healthcare organizations, as well as the public, so that the public knows where to go when they need access to services for regular healthcare, as well as what to do when they get a cold. Planning for the workforce attrition is also a big challenge, and I think here's where the public health community and the healthcare community needs to actually learn lessons from the disaster response community and the military, who do planning of shift schedules and rotations and planning out your workforce in case of attrition. They do this really well, and we need to learn that better in the public health community. There's also, as we all know, of course, COVID grew exponentially, and the need for nimbleness and agility and flexibility, I think, was a recurring and painful lesson for many of us. But these questions of surge capacity are still persistent. How can we respond swiftly and appropriately in ramping up testing, tracing, isolation, quarantine, manufacturing of production of PPE, which, by the way, is not only for COVID, but also for maintaining access to essential health services. And so in that sense, there are constitutive or spillover benefits to ensuring rapid access to PPE to ensure that the regular health services can continue. In terms of sort of the other key message I want to communicate is the role of collaboration, which I think is another buzzword and keyword that we tend to throw around. But I think we should really emphasize this, and I think it's also drawn out in the report, and that also relates to communication. So it's, while we assume that sometimes the government is responsible, the government also needs to recognize it cannot be all things to all people at all times, and that it needs the partnership of others in order to address this whole of society challenge and crisis. And to that extent, collaboration requires communication with many different organizations and people. So it requires communication with the public, it requires communication with partner organizations, and it also requires communication within the government. And so in that sense, the efforts for communication to improve collaboration are extremely challenging. It's really hard to do communication and therefore collaboration well, because there's so many partners that need to be communicated with. The engagement with the vulnerable communities also requires trust and communication, and that communication can be built upon working through organizations which already have the trust of these hard to reach or vulnerable communities. And I think to the extent that the governments can recognize their own limitations and seek support to build that capacity in times of need is really crucial. I just want to mention, in terms of the challenges that the world is facing, we all know, but just a sort of unfriendly reminder, unfortunately, that governments around the world are facing many challenges, economic pressures, macroeconomic environments very, very dire. Rising debt will translate to fewer resources available to the government and potentially changes in priorities, what the government can focus on, and lots of competing priorities, which are also pressing and important. You know, other disasters that we're facing, climate change, food insecurity, these are all bubbling up to the surface. And yet at the same time, we also need to continue our focus on pandemic preparedness, and raising the priority of this topic will require all of us, including civil society and others, to continue raising these questions that the government can help to lead on. And perhaps one approach will be to link these issues of pandemic preparedness to emergencies more broadly, and thinking through streamlining our emergency responses. Just briefly mentioning the Pandemic Fund, which was created after in response to a recommendation from the G20 High-Level Independent Panel report. The Pandemic Fund was launched last September. Some of you may know there's going to be 13 or more implementing agencies, which will be the channels of the funding for this support that will be dispersed to countries, and applications are due in May. And the first round for $300 million. Not a lot of money, frankly, but we'll focus on surveillance labs and human resources. And I think the investments in surveillance for pandemic are also investments in surveillance for public health and universal health coverage in general. And I think we really need to emphasize this, that what we're investing in is not merely for the pandemic, but also just for the health system and universal health coverage more generally. I do think that we have important questions to ask about the ways in which this highly verticalized global health aid architecture has actually been focused on many infectious diseases, but they may not, I think it remains a question, open question about the extent to which these global health vertical initiatives have or have not supported flexible, agile, collaborative systems for respiratory infections and pandemics. course, the WHO has come up with some new frameworks, the PRET, the Mosaic, the HEPR. These are all important, helping us think through some of these questions. But I do think this challenge of vertical and horizontal initiatives really needs to be at the center of all of our discussions. Otherwise, we risk sort of reinforcing this verticalization of sort of any type of pandemic approach. We really need to start thinking through building these horizontal integrated approaches that are flexible and collaborative and agile enough to respond to the next big one. I'll stop here. Thank you very much.
Thank you very much indeed, Victoria. And we will now move from two very disparate frontline regional perspectives, the first from West Africa and the second from Hawaii and the Pacific, to the heart of the World Bank response. I'm very pleased to introduce Marilise, who was the co-task team leader of the COVID MPA, which is the largest and fastest project in the World Bank's history, and an invaluable source of support and leadership to all of us as we strove to bring this project to the board in record time. She's also the task team leader of our HEPR, our Health Emergency Preparedness Response Fund, which is our largest preparedness trust fund. And she also leads our work on digitalization and innovation. And I'd like to ask Marilise to focus on partnerships and on innovation. And I will just say that I think we saw extraordinary advances in the life sciences during COVID, compressing decades into months and years. And we saw some promising glimmers in other areas of innovation. So Marilise, could you tell us how you feel partnerships and innovation served us during COVID?
Excellent. Thanks very much, David. Just to make sure that I'm heard. Excellent.
You're good.
Thank you. So thank you for the opportunity to share some thoughts today. And I also want to thank the colleagues from the IUG for a balanced and excellent report that reflects something that I think was really unique in all our lifetimes, right? The fact that, and that was my first reflection on partnerships, is informing partnerships and thinking about innovation is really that they were essential because we were forming them at a time that all of us simultaneously were in a time of crisis. And I think that brought about a spirit of humility and curiosity and urgency in how we could build the most productive partnerships. And so we saw during COVID really a flourishing of partnerships in three key areas. First is within the World Bank. So we have seen for the first time projects that are co-led by colleagues from HNP and agriculture. We saw closer collaboration between health, nutrition, and population and our education and social protection colleagues. For example, using the social registries that our social protection colleagues use for grants in determining, helping to prioritize vaccine rollouts. We also saw partnerships with our energy sector management assistance program, making sure that the solutions that we were building for COVID and supporting in country for COVID vaccine rollout were done in a green and environmentally friendly way through solar panels and even some electrical vehicles in some countries for the distribution of vaccines. Victoria has mentioned, and I very much agree with her, on the importance of closer collaboration with our disaster risk management colleagues. Our global program for disaster resilience and recovery and ourselves from health, nutrition, and population side, forged a close collaboration with jointly funded efforts and thinking institutionally how a COVID-focused emergency operations center and a disaster risk management agency at a country can come together. Of course, the second type of partnership is between the World Bank and other partners. We think here, for example, on partners relating to the urgent response for vaccine rollout, as well as the partnerships that the World Bank financed, and this is the third kind of partnership with countries. The REDISET program that Cesare mentioned earlier is a good example. There are also other examples where in East and Southern Africa, a new regional partnership was formed for countries to really do much more intensive peer reviews of and peer assessments, understanding how they can form in the sub-region better regional approaches, understanding that infectious diseases don't respect boundaries. And we've seen with the Africa CDC how important regional responses were to COVID-19. As countries prepare for not necessarily COVID, but other future health emergencies, be they infectious or non-infectious in nature, we're also seeing interest in regional partnerships for pandemic preparedness and health emergencies in places as disparate as Central Asia and South Asia, and even in East Asia contexts where we've not in the past seen regional approaches to these complicated regional challenges that really requires regional solutions. Lastly, I want to focus just on innovation. If we think about innovation, the first and foremost is the service delivery innovations that we've seen. Telemedicine, there's an absolute uptake, was an uptake during COVID-19, but we see the durability of the interest in that innovation for telemedicine and e-prescriptions to become a routine part of health service delivery and not just something that we rely on as a second best or an alternative service delivery model when there is a crisis. Second, the service delivery innovation that I think is always worth mentioning in this context is the rapid ways through which grants could be rolled out. We know from our colleagues in social protection, for example, the Navisi program that's been well described in Togo rolled out grants within ways of the government deciding that they were going to expand grants to informal workers who lost their income when there were lockdowns. And that absolute rapid rollout process was only possible because of the digital systems and the unique identities that were in place that enabled them to very rapidly identify who needed those additional grants and how they could get the grants through mobile money delivery methods to these grantees absolutely as soon as possible. We also saw some technology innovation. And again, here I'm delighted to note that there is such interest in these technologies, not just for time of crisis, but applying them in a routine health system context as well. For example, of drone delivery for not just emergency or vaccines, but also for routine health service delivery in Timor-Leste is one program that we've supported, as well as the significant advances in information systems and using the COVID vaccine registries and embedding them within routine surveillance systems, and in ways to take what we've learned and what was built for an emergency purpose, but use it for wider scale essential health service delivery. We also saw significant innovation in measurement and in surveillance. We think here, for example, of genomic surveillance, we think of wastewater-based surveillance, and the repeated rapid phone surveys that our colleagues in the CUGH did together with our colleagues in the development group. So really ways I was in fact halfway through managing an impact evaluation that was not COVID focused, that was of a digital health intervention. And we had to rapidly switch between face-to-face data collection methods and phone survey-based data collection methods. So, and the rapid guidance that came out in terms of how we could do that. And lastly, I want to mention about the process innovation. And here particularly, I think Stephen mentioned in the overview presentation, the different ways through which the bank did procurement, through these mechanisms called bank facilitated procurement, where it made it a lot easier, a lot quicker, and a lot less cumbersome and complicated for countries to do procurement of goods that were not rapidly available at a time when the global marketplace of health commodities and health equipment was just broken in ways that I think we've all experienced daily in our lives, but also just how these types of procurement mechanisms could rapidly coalesce and bring together tools and options for countries that otherwise, if they tried to do this individually by themselves, would not have been possible to do. And in closing, I want to just say that I think to me, one of the most important lessons, and it really spans, partnerships, innovations, and how we think about health systems moving forward, is this false dichotomy between times of crisis and times of non-crisis. Not all health emergencies rise to a global or national level. Not all are infectious in nature. Not all spread as fast as COVID did and affects everyone simultaneously. But in local ways, individual health facilities, individual health providers, healthcare providers, the health workforce districts face small health emergencies, small crises, and potential crises on a day-to-day basis. And I think the lessons from these partnerships and innovation and help build systems that can handle the ebb and flow of more healthcare, less healthcare, and the different kinds of healthcare that needs to be provided. We can take what was an absolute global devastating crisis and try to build on it in ways that are positive and that can be transformative for the health sector moving forward. Thanks, David.
Marvelous. Thank you very much indeed, Mary. So now I turn to our last panelist, a long-standing friend, colleague, and mentor, and the champion of Africa's early HIV response, Dick Seifman, who will talk about community engagement and demand side, which has been so important during COVID. Dick, over to you. And you're not visible or audible yet. I wonder if the internet hasn't let Dick down. Can you all hear me okay? I wanted to verify it's not my internet, that sometimes happens. I think I hear you. Over to you.
You hear me? Good. I don't know what happened, but electronically there must be a double. The good thing is that there are so many good comments that you had from the various panelists and also from Stephen and Jenny that congratulate IEG for a fine evaluation. But I do want to touch on a couple of points which have been made by others. Certainly in that 15-month period, the bank was very effective in providing emergency funds, in procurement, in distribution of various resources, and in reaching health facilities and even health workers. This is what I call, from my perspective, the supply side of a pandemic response. What was not as equally well resourced is the engagement of people to, in fact, draw on the resources that were made available from the supply side in terms of responding to COVID. And the COVID situation is perhaps even more particular in terms of the issues of trust in the health system and health advice, in part because there was such an effective, unfortunate effective anti-vaccination campaign that was found both at the international level and also at local levels, which in fact made people very suspect of what they were getting. In fact, it was of such a magnitude that the World Health Organization felt necessary to create an informatics window that identified all of the accusations and the responses so that people who were trying to combat this very substantial attack had ammunition to fire back. What was needed, I think, and we might have learned it also in the old days of the HIV response when we had nothing but prevention, is that you need to engage the national governmental organizations. You need to get religious leaders. You need to get local politicians. You need to get the private sector whose employees and workers are in jeopardy from a COVID infection. You need them to be speaking out, quickly educated, and then actively supporting getting preventive services. This might have been more effectively pursued in the COVID context. One point that I wanted to then sort of address in some depth is the issue of One Health, the animal, human, plant, and ecosystem interface. And I describe the period that we're talking about, the 15 months, as no wine before its time. And by that, I mean that at the time that we began this process, there was funding that might have been available, but was largely taken up by the health sector for a lot of reasons. That was where the people were reacting as proactively as possible. Secondly, the sectors were really not useful, not used to effectively collaborating and coordinating in a pandemic emergency context. Third, there was no accepted operational definition of One Health, and nor was there an operational framework for One Health, which in fact the bank has later produced. And that has changed, and has changed in a number of ways. One is you have the bank's operational framework to draw on, and has been drawn on, and others. You have an agreed upon operational definition created by the One Health high-level expert panel composed of, excuse me, FAO, WHO, UNEP, and WAHU. And what you now have fairly recently is those four leaders getting together and creating a call for action in which they identify 7 specific actions that need to be taken. And so let me just give you a flavor of what those 7 actions are, and they're relevant to as we look at the past and in the future. One is that the need to prioritize One Health in the international political agenda. 2, strengthen national One Health policies and programs. 3, accelerate the implementation of One Health plans. 4, build intersectoral One Health workforces. Strengthen and sustain prevention of pandemics. And I want to go back to that point as well. When we often talk about prevention, many see it as primary prevention. That is to say, containing an infection that is in a localized area, and or even more so. But when you really take a look at prevention, spillover prevention, the transference of an infection from animals to humans, is really where you have the most proactive and important response to avoiding the kinds of things that we have spent billions on, as well described by a variety of the speakers. So I wanted to make that point, that the need for surveillance, proactive surveillance, not just in the health sector, but also by the veterinarians, by the wildlife service, and so forth, is a way that we will perform better, or could have performed better in the past, and hopefully in the future. And I know time is short, I will stop there.
Thank you for being so succinct. And this gives us time now, I think, to maybe invite some wider participation. Could we perhaps take some questions? Stephen? Jenny? I think we have time for a couple of questions, right?
I mean, one of the things I can emphasize, which I've seen in the chat, is that the importance of different partnerships, which I think has come up across the different panelists as well, in terms of community partners, the community roles and implementation. Private sector, universities have come up. Yes, what we saw, it was this preparedness really, it needs to have roles of different actors, and that was something that could be developed, but also integrated thinking about the different levels of the response, the regional, the national, the community, the different kinds of roles at each level was also important. And then the monitoring, I think that the surveillance is really important. It's definitely come up, but then also the understanding of vulnerable groups and this feedback as well, and how, so thinking more complex ways about how that can work.
And maybe David, just to sort of redirect a question from the chat back to the panelists. We're talking to the consortium of universities, as there's a question about what have we learned through this about the role of universities in our partner and client countries, about how they can help respond in future pandemics and preparedness efforts. And I think they'd like to hear some views from the panelists, what they saw in the pandemic, but what they might think of in the future in the role of universities.
Thank you, Jenny and Stephen. And could I invite panelists to address this issue and also to scan the questions in the chat? And also colleagues who'd like to ask verbal questions, please do prime yourselves, because we'll move to some verbal questions as soon as we've dealt with some of the recurrent chat questions. So I see Victoria has a hand up to respond, so please do.
Thank you. This question that Professor Wasserheide has raised about the role of universities in supporting and responding to pandemics is one that's very close to my heart, having worked at the University of Hawaii, which is a state university, and worked very closely with the state government. And in terms of the kinds of roles that universities can play in terms of supporting pandemics and responding to pandemics, I think is varied in terms of the whole spectrum. The University of Hawaii alone, for example, supported testing. We ran a call center for isolation, quarantine, and also mental health. And we also did our COVID modeling task force for the state through the university. So there's some work at the WHO in terms of the role of modeling for informing COVID and pandemic preparedness. And I believe the University of Washington as well was also quite influential in their use of models. So in that sense, I do think the role of universities in providing that technical expertise for forecasting, as well as scientific knowledge and guidance, particularly to local governments, is really crucial. I think this is an opportunity for the university community to really think through how it can engage and raise the profile of universities, particularly local universities in low and middle income countries. And related to that is also the workforce development piece, is how universities train students who can be part of the public health workforce, and building in that pipeline for the challenges that we're facing in terms of burnout and attrition. I would love to have further discussion with you, Professor, on this topic. Over to you, David.
Thank you, Victoria. Marilise, and then Jack. Marilise, please go ahead.
Thanks very much, David. I wanted to address the question that Keith asked about how university can be most useful. Very much second what Victoria said. There's also a new Lancet Commission that's forming on the use of epidemiological modeling for preparedness and for routine health service delivery planning. So this is obviously a topic that's very pertinent. Over and above that, I think that universities can play a role to bring the skills in epidemiology and the skills in emergency response management and surge rollout closer together. I think when we look at the folks who are trained in emergency management, they don't always sit or interact with people with a global health or epidemiological background. So I think bringing those two communities closer together and having a global health workforce that is surge capacity ready for rollout and rapid implementation, I think would be good. The other area is in digitalization. You almost can't talk about healthcare or healthcare planning these days without thinking about digitalization and how we use digital technologies, systems, and data for better planning, management, and evaluation of responses. I think a global health workforce that is digitally ready to help to engage in this space would be very useful as well. Back to you, David.
Brilliant, Marilise. Dickon, and I'm glad to say Cesare has also joined. So let's have panel comments. And then I want to prime audience members. We'll be inviting verbal questions to complement the excellent chat questions. Dick?
Again, I may be having electronic problems, but it's my virus, not yours. What I was going to say was, one, I did manage to see in one chat question from Keith Martin about their work of CUGH with One Health, offering to give me or give us access to their efforts with the 4 UN agencies. And that would be something that I would certainly welcome. The other point I was going to make with regard to the pandemic fund, it was initially entitled Pandemic Prevention, Preparedness, and Response. What I'm going to be watching or hoping that when they get down to the issues of prevention, which is not often mentioned, that they really do allocate resources for the whole raft of preventions, from both spillover issues as also from the normal primary prevention phases. And my last point is that the 4 UN agencies that have spoken up and stood for this call of action offers an important platform for everyone across this audience to take them up on their promises, to see words translated into concrete action. So let me stop there.
Thank you, Dick. And I'm going to invite Cesare to speak. And just to apologize, despite the excellent preparation of our IEG colleagues, I've misdirected myself and we can't take verbal questions. So please continue to participate through the chat. And Cesare, over to you.
Thank you very much. I would like to elaborate also a bit on the university participation and this in this important agenda. Like I mentioned earlier, for the FLTP master degree program, in order to avoid having this program across country, which is not cost effective, in that we have some center of excellence. Like we have in West Africa, we have already the University of Ghana and the University of Ouagadougou play the role of center of excellence for the whole West African country, training high-level staff in FLT. It's something that can take to scale in the other subjects as well. If only in West Africa, we have such an example. It's something that can be also considered for the remaining region. And I think Africa CDC has the whole mandate to ensure the rollout of this agenda. I would like to also elaborate a bit on the One Health agenda. Actually, I think we are happy that in West and Central Africa, the One Health agenda is something that is taken seriously by all the member states and also partner involved in the sector. So we have the platform established across countries. We have technical work group set up. We have governance body already in place. But what we need to work on seriously is how to have downscale strategy so that we make sure that One Health is practiced. We know when we say One Health implementation is ABCD at operational level. If we don't reach that level, it may be missing a key piece, and that's why we are putting for that. We were in a meeting with WOW last week in Senegal, and we told them that this is the piece we need to all work on so that at the end of the day, we know what One Health is about at operational level across the different sectors involved in that approach. Over.
Marvelous. Thank you very much indeed. Participants, please do keep putting questions into the chat. And panelists, please do scan the chat. And we are approximately 15 minutes to run. We'd intended to save a couple of minutes for final panelist statements. But if the questions continue to come, we can merge those into the Q&A. So can I invite panelists to scan the questions? Can I invite participants to bump questions up or to return to us if they'd like to clarify things? And let's keep the Q&A flowing. I see Aranjana, who's valiantly stayed on despite losing power as the house next to them is being demolished and joined by phone. I would like a panelist to speak on a specific issue. Panelists, could we scan this?
One of the questions from panelists was relating to health human resources and how this is a big challenge. And maybe one of the panelists has a response to the thinking on this.
Love to throw that question to the panel. And all I would say is I don't think we've yet fully comprehended how much we've lost in the way of health human resources through COVID. You know, the Great Resignation has really affected health systems in ways I don't think we've begun to understand yet. So this is such a good question. Over to the panel.
Thanks, David. Maybe I could venture first since the question was directed.
Yes.
So I think first to agree with David, there are assessments, particularly in Africa, that the World Bank is working on at the moment to understand the scale of the devastation in the health workforce sector, not just the current health workforce, but also how the pandemic and what is known has affected the future health workforce. In other words, how much people want to be involved in delivering healthcare in future. Is this going to affect our pipeline beyond the challenges we already face? One of the other areas that we're also finding and working closely on with our education sector colleagues is that with the innovations that I mentioned earlier on, they are obviously excellent for addressing some of the pernicious challenges in the health sector, but they do come with their own challenges. And one of them is the technical staff that are needed to maintain these innovations. For example, if we have advanced new laboratory equipment or other digital technologies, we need a health workforce that can not just deliver services, but that can also use these new technologies. So I think one part of that answer to the health workforce crisis and what may well be an exceeding crisis in the future is to think about how we can use digital technology to relieve some of the pressure on the health workforce, but also working really closely with our education sector colleagues in making sure that we have a relevant focus on the pre-service training. And then I think another area that the bank is also working on is on the mental health aspects. I think there is significant mental health challenges amongst the health workforce, and those are areas that we have to keep addressing through our bank investments as well. Thanks, David.
Thank you, Marlies. I really like that point. And I would just emphasize how important it is to make sure the whole system for the digital ecosphere is there. Because digital health has potential when it's linked to remote connected apps, for example, that can do eye, nose, throat, pregnancy, and other scans remotely, and to lab and diagnostic work. And that's the challenge before us, I think, if we're to reap the benefits of digital. So other panelists, please. Marlies, did you want to come back on that? Or other panelists, please do chime in. Stephen, I see a hand.
Thanks. Yes, and as myself, I had to switch to a phone as they locked down a house next door. I think just reflecting upon the comments in the chat and thinking about the process of the evaluation, I think something that we started with in conversation with Dick and we kept coming back to was the preponderance of the biomedical response, rather than thinking about the essential health services and the community and the social aspects of the response. And this reminded me of the HIV and AIDS pandemic and epidemic, especially in sub-Saharan Africa. So I worked at the University of Witwatersrand in the School of Public and Development Management, and also engaged with its health consortium. And thinking about the university role in this, what I saw is that a very strong role in the sort of understanding the terrain, especially in the local community being Johannesburg, but also being able to undertake those sort of more rapid, complex forms of monitoring. And I think this is something that we saw missing in the COVID response, was this ability to switch to sort of log quality assurance surveys, to be able to sort of understand local outbreaks and to be able to understand that and bring that up through the spheres of government. And I think this is something Jenny spoke to in the chat as well, is this absence of this switch to more complex forms of monitoring and surveillance to provide the more rapid feedback loops first upon some sort of sampling and surveillance. And I do think there's something in the role of universities that I recall from the HIV responses in Johannesburg that were particularly valuable, and there were data sets that we'd often draw upon in understanding how the disease was shifting and where it was happening. So I think that's drawing together different strands in the chat.
I think that's a wonderful point. I would really just underscore too how extraordinarily rapidly COVID unfolded compared to HIV. You know, having lived through both, I look at HIV as a slow motion pandemic compared to COVID, where many of us were immersed in one issue for 2.5 years, and then it went away and it's gone from all of our lives. So I think it's the ultimate test of how rapid and flexible and adaptable we can be. So thank you for highlighting that. Victoria, and then Dick, either an old or a new hand.
Just responding to this question about human resources, and I completely agree with Marlies and Stephen on these points, you know, strengthening the education sector in particular as a way to build the workforce. I think the particular question I think that Keith was raising was with regards to ministerial workforce and government workforce in particular. I do think this is an important question to discuss in terms of the role of government relative to, say, nonprofit delivery organizations. For example, we published a blog not too long ago, which showed that funding through the Global Fund, for example, has been increasingly supporting non-profit or non-governmental organizations as opposed to governmental organizations. And of course, the type of funds from the bank are not necessarily for recurrent costs. And so I think those are, which would cover staffing and so on. So the ways in which the pandemic fund can provide a carrot for countries to increase those resources for human resources is a big challenge, also given the sort of more sort of fiscal environment, which is quite challenging, just as fewer resources available. But I think these are really challenging questions, but one that I think we should not neglect, because if the government should be leading the pandemic response, which I on a personal level believe, but in terms of how that's actually translated to resources and sort of global health priorities, I think is a big question. And even as we look at just a few days ago, the Human Resources for Health Forum and things like that, and there hasn't been any move towards supporting that. And I think these are just vexing questions where the global health community has tended towards investing in highly vertical approaches, tending towards supplies and products, and not really thinking through how the system and sort of the ongoing human resources can be strengthened. And then just the last point on the universities, absolutely, I just feel very strongly this is a really crucial point. And our research on PEPFAR, for example, was that one of the largest, sort of most frequent contractors of PEPFAR were actually US-based universities. This was about 10 years ago. And that, not surprisingly, as Stephen noted, that universities play a very important role in responding, at least to the HIV pandemic. So in that sense, I do think thinking through the ways that global health supports universities as a means of developing knowledge, science, and technical public health know-how and capability, I think has been a neglected area, to be very frank. And I think it's worth really thinking through how global health can better support that. I'm over to you, David. Thank you.
Thanks, Victoria. And also maybe just slightly controversially to suggest we think about the role of universities, because I think PEPFAR has been remarkable, but using Ivy League universities to deliver primary healthcare services in Africa may be a suboptimal niche for them to ultimately occupy. So thank you. Over to other colleagues from the panel, the chat. And we're 6 minutes to go. If it's okay with colleagues, I'd suggest that we combine answers to questions with our closing statements and finish comfortably at 11:30. Thanks, everybody. And Dick, thank you for physically raising your hand, which I think I saw. So over to you.
Yeah, I was perhaps doing both things that you've asked for in a sense. I think one thing that we've seen is that there had been no infectious disease emergency communication strategy. And I think it is something that we should, in fact, consider across the board in countries, because we are going to have additional infection disease outbreaks. We are going to need better communication strategies. And we need to engage not just the Ministry of Health, if there's a Ministry of Communication and or the universities. It needs to be all hands-on effort, because that weakness of the demand side of the equation seems to me to be our most vulnerable spot. And I just want to say this has been very informative, useful, and I appreciate what you've done, David, and also obviously what the panelists and Jenny and Steve put together. Thank you.
David, you're silent.
Apologies. You think I know it after 3 years. Suzanne, my apologies. Over to you.
Thank you very much, David. I think I would like to express 2 points as maybe the closing suggestion. The first thing might be our new operation and support might address human resource capacity across Africa. Human resource capacity is very important. Yeah, we're talking about digital health, we are talking about the role the university can play to support. But we need also to think about mostly about how to increase capacity across the region. That is paramount. The second thing, we mentioned the role of the university as well, but I think in complementing that role, we need to come up with longer-term strategy, including investment in research and development in health technology, such as local vaccine production capacity, for example, that we don't have in Africa. This will shield the region from over-dependence on overall community to meet local needs. Why am I saying that? In the midst of the COVID, most of countries they have financing, but it was difficult for them to mobilize quickly the vaccine and other supply they need to address the COVID-19. Those are the area of thinking we need to consider going forward.
Marvelous. Thank you very much indeed. Other panelists for closing reflections, answers to questions as you continue to scan the chat.
I'll just add that I think it's really important to remember those innovations that were identified during COVID. There are lots of successes that can be built on, and they weren't the norm everywhere, but they are evidence that things could work, and they need to be looked at more closely to see which ones are the more useful. In terms of reaching vulnerable groups, in terms of communication, in terms of monitoring, there are examples of all of these things that were done during COVID.
Beautiful, thank you. Marlies, Victoria, any closing thoughts for us?
Victoria, over to you, and then I'll close out.
Okay, sure. You know, I think the pandemic was an unprecedented crisis, and yet the world continues to face more unprecedented crisis after crisis. So I think we as a global community and in our local communities need to continually take these crises as opportunities. How can we take this opportunity as a crisis to build upon and grow things beyond just that particular narrow focus? I think that's the broader takeaway lesson for myself. Over to you, Marlies.
Thanks, Victoria. That's a perfect segue into what I was going to say in closing, which is that, be it an infectious disease or other emergency, the pressure on and the demands on the health sector is only going to increase in the future. It's already increased, and I think it will only continue to grow at levels we've not seen in our lifetime. There was a study published recently that suggested that 54% of the known infectious diseases today will increase in terms of duration and geographic scope and intensity because of climate change. That's just more routine health services, more people who need more healthcare for longer periods of time, notwithstanding the significant chronic disease burden that the health sector has to shoulder as well. And I think we are only going to be successful in this if we break down the false dichotomy between pandemics and routine health services on the one hand, and on the other hand, if we are laser-like in our prioritization of what is it that we need to do to protect the most vulnerable, to deliver the most efficient care, and to deliver the most health for the most people. I think that the CUGH community of academic institutions and other partners are all an essential part of helping to make this happen. We need to do more, we need to do new and innovative things, but more than ever, I think the collective responsibility for all of us to just be as efficient and effective as we can with every scarce health dollar that is available is a collective challenge that I think we all play a role in helping to solve. Thanks, David.
Thank you, Marlies. And I will simply conclude by saying I have many happy memories of participating in CUGH events before COVID. We're very grateful to CUGH for lending their wide-ranging, far-reaching and prestigious forum to us. We're extremely grateful to IEG for their usually thoughtful and insightful work, and to the panelists for this excellent discussion. And we'll close on time with much appreciation to everybody. Thank you and goodbye.